and I guess what we just saw is why we watch live cases, because anything can and will happen. It was a tough case, and let me preface this by saying that standing up here, you can always criticize or say, well, I would have done it differently, and that's not entirely fair. I think one of the retrospective analyses for that last case that was brought up with the last question was the angle of the epicardial access. When you saw the epicardial access being obtained, it was nice, it was lateral, but it was kind of too lateral. When I looked at it, I thought, well, that might be a problem. And the thing about the Lariat, and I'm sure Randy can tell you a lot more than I can with a lot more experience, but if everything is aligned properly, it's generally really easy. And if anything is just even a little bit off, it's suddenly very difficult. And so the Lariat tends to flip over backwards if you have any kind of secondary curve on the epicardial access. So that was a tough case, and it was almost about halfway through it, I was thinking, you know, that what they might want to do is just stop and re-stick and stick a little bit more vertically. I don't know if Randy has a thought about that. But okay.
No, I would agree with you, and that's what BJ and I were talking about also.
So anyway, this is just a quick, and again, this was something I had prepared in case it became relevant. This is just a Lariat case that we did, and frankly, this is the only unsuccessful Lariat that we've had, and there's a lot to learn from this. So this is our RAO view of the angiogram of the appendage. You look at that, you think, okay, that looks pretty straightforward. The LAF view was like this. Now, if you look carefully, you think, okay, that's not terribly complicated, but there is actually a little bit of late filling just on the lateral edge of it. And when I looked at that, I thought this could be problems, because really to get the Lariat positioned properly, you have to be flush all the way down, sort of at the level of the circumflex for it to work. So here's, we're just kind of running through quickly. We already have epicardial access, of course, endocardial access, and we have our Lariat all the way over, so we've kind of fast forwarded to this point. So it looks like our Lariat is all the way down, prolapsed all the way over the appendage. So it looks really good. So we've closed it, but this is, before we release the suture, we close, and we have to be absolutely sure that we're happy with the final closure, because once you release that suture, it's a little bit like deploying the Watchman. That's it. You can't undo what you just did. Whereas if you just close the Lariat and don't release the suture, you can open it up and reposition or do whatever you want. So this was closure. And if you looked at it, you thought, well, gosh, that's probably, let me go back, probably reasonable closure. But this is what we were faced with. You see, this was the part of the appendage that we had closed, and it was nice and smooth there. There was a secondary lobe down here, and that's what was missed. Because if you looked at the CT, because I went back and looked at the CT knowing that there was this little Mickey Mouse ears type of appendage, or two separate appendages, that secondary lobe did not fill at all. And so a CT, if you use the standard automated segmentation software, requires a certain difference between the Hounsfield units, or the density, for it to be able to segment these things. And if it's not the same, if it's very similar to soft tissue, it's not going to pick it up at all. And so this is an example where the CT did not see that at all, but that's still relevant. I mean, as the secondary lobe, if we closed that primary lobe, it's debatable whether we would have done any good. There's some arguments that incomplete closure, at least in the surgical experience, actually increases the risk of thrombus. So we elected to abandon and just pull out, and that was our decision. And I don't know whether that's the right thing to do, but we had opted for, we actually referred the patient for surgical closure in this particular case.
Did you have a TE echo? Did it pick up the other lobe?
They did not pick the other lobe of the TEE at the time. It was really not until we did the angiography, and this was the first time we saw that secondary lobe. And it's just kind of a lesson for us to learn from, that, as Andrea said, at 130 degrees.
It was very posterior. I think that's probably why. It was completely different.
Well, they should have seen it. I mean,
yeah, Ronnie, so it's very important to emphasize to look at the appendage at that 120, 130 degree angle. So you see the anterior posterior separately, And if you have a fish tail type of a thing,
Yeah.
you'll
Yeah.
see it.
It should have been picked up. I totally agree with that, but it was not picked up live for our case until we did the angiography.
Yeah, but I think what DJ was saying is to really get a good echo right before you do the study. Because we did a live case at TCT, same sort of thing. The CT looked great. The echosonographer saw a lobe that went behind the pulmonary artery.
There was,
Randy, with this type of anatomy, would you be tempted to try and do it with two Lariat devices, close one and then the other?
You could theoretically, but, I would agree with Rodney. What you'd be left with is probably, it looks like a 2 centimeter neck, plus there's some trabeculation inferiorly. So, with our next generation, you could do that, but not with the current. I probably would not have.
it probably, the other issue that we had, because one was posterior, so it probably would require a completely different entry point of the Lariat, anterior for the typical location, and then a completely different stick posterior for this second one. So it would have been, so we decided to sort of not.
Lariat holds themselves to a very high standard of complete closure, and in a standard that, frankly, the other devices maybe don't. And these very small leaks, which we see very commonly with some of the other devices, and the early literature looks okay. I think one of the tricks is to understand if these very small leaks are really as small as we think they are or not. And that live case was a perfect example where it looked very small, but it was unclear if it was really a little peri device, 2 millimeter jet, or if it was an uncovered lobe. And I don't think we fully defined that. But